My name is Kim Dennis. I'm a adult psychiatrist, addiction medicine trained, and a certified eating disorder specialist. I'm the chief medical officer and CEO at SunCloud Health. This is our about quarterly grand rounds. We're delighted that you all are with us. We treat adults and adolescents from a transdiagnostic treatment perspective, and many of our patients have complex co-occurring eating disorders, substance use disorders, trauma-related disorders, mood disorders, and anxiety disorders. And at SunCloud, we have PHP or full day treatment, IOP, as well as residential services currently for adults and starting next month in a couple of weeks for adolescents as well. So we're very excited about that. And we are in the Chicagoland area. Sal, my teammate here at SunCloud, will be putting our contact information into the chat. Donna will be your point person if you have questions about SunCloud or questions about obtaining your CE or CME from this activity. So, without further ado, I am going to introduce Dr. Guido Frank. At SunCloud Health, we believe in science and we pay attention to science and we use science to inform our clinical practices. Um, okay. Dr. Guido Frank is a board certified psychiatrist specializing in the care of children, adolescents, youth, and young adults. He provides care through the UC San Diego Adolescent Psychiatry and Eating Disorders Center. He is the director of psychiatry at the Rady Children's Hospital Medical Behavioral Unit. He believes in using a compassionate, patient-centered approach, emphasizing thorough assessment, evidence-based treatment, and collaboration with patients and their families. He is a professor of psychiatry at UC San Diego School of Medicine, where he mentors medical students, residents, and fellows. His research focuses on the brain biology underlying eating disorders, including anorexia, bulimia nervosa, and binge eating disorder. He leads and participates in numerous clinical trials aimed at identifying novel treatments, improving outcomes, and preventing relapse. His overarching goal is to make treatment more effective and accessible while advancing prevention strategies. He is a recognized expert in our field. He has received numerous honors, including an NIMH Mentor Recognition Award and the Eating Disorder Foundation's Greg Huney Memorial Award for Excellence in Research. And with that, I am going to turn it over here to Dr. Frank. Thank you so much for all that you do for the field and for patients, and for being willing to share your expertise with us here today.
Thank you so much for having me. Okay, I hope that's visible. So again, thank you very much for having me and having me back and being able to build on what we talked about last time I was here. And today I'd like to talk about ketogenic nutrition as a treatment for anorexia nervosa. And what I'm hoping that you will get from this webinar today is that you will be able to discuss how anxiety and stress may affect brain metabolism, how a ketogenic diet, dietary therapy, I really rather want to call it, may be helpful for anorexia nervosa, something that very often makes people raise their eyebrows, and it seems very counterintuitive. And I want to say it was counterintuitive for me too when I first heard about it. And I show you in a bit the process I went through to then really believe in it. And the clinical data are very supportive of this approach. And then I will discuss how 12-week ketogenic nutrition changes behavior, and would like you then have you a good background in what happened in that study that you could then think more about yourself and maybe also share with your patients. So anorexia nervosa is characterized by restriction of energy intake relative to the body's requirements, right? Those people starve themselves to a very low body weight, essentially to death, literally. And while people are very thin, lose weight, they are preoccupied with an intense fear of gaining weight or becoming fat. And it almost seems like the more people starve themselves, the worse it gets, paradoxically. And they feel themselves, they experience themselves as fat and overweight, while they're obviously not. And shape and weight are really main contributors to self-esteem. And there's also this really particular denial of the seriousness of the condition, right? People are in the hospital and they have a very hard time understanding why they would be hospitalized while the heart rate goes in the 30s overnight and so forth. So there seems to be sort of a disconnect of medical effects of the illness and how people really can recognize the illness's seriousness. And then there are other very important associated behaviors that are not really part of the diagnostic criteria, which are high anxiety, high state and trait anxiety, harm avoidance. You probably have seen people being working very hard, very perfectionistic. Very often people are straight A students. And what's also really important is this intolerance of uncertainty. I just feel uncomfortable if I don't know exactly what's happening. Doesn't really matter if it's good or bad, which is sort of an underlying trait for anxiety and generalized anxiety disorder. Then people are also very sensitive to punishment. So people really want to avoid doing anything wrong. These are sort of biological traits. And then the onset is typically during adolescence, and puberty is a critical risk period, which also, of course, leads us to think that biology has an important part in this problem. And anorexia nervosa is a very severe disorder. It is associated with a high death rate from all causes of death, much elevated compared to the regular population. A recent, relatively recent review on treatments for eating disorders highlighted really that there's an urgent need of novel treatments, and in particular for anorexia nervosa. So this was a huge systematic meta review of meta-analyses that then really, again, what we all kind of knew, highlighted with a lot of data that we do not have very good treatments. Psychotherapy is the main treatment modality. It does work. It is very helpful, but there are no biological treatments that have been approved for anorexia nervosa. And paradoxically, during weight restoration, anxiety and distress over weight gain and body dissatisfaction often rise, so increasing the risk of relapse. And while we can help people gain weight and make people have increased intake, especially on the hospital level, when people even get an NG tube placed and so forth, the core problem, the cognitive emotional parts, are extremely difficult to tackle. And I don't think we have something specific that really gets at the mechanism of treating these fears about weight gain and body satisfaction. And over many, many months of treatment, then often things can get better, but it's a very, very long process. And my personal experience is that after high intensity treatment, when people are in their regular environment, if something stressful happens, if difficult life events happen, it can be very easy to slip back into food restriction, and the whole eating disorder syndrome reemerges with full force. So there's really a lack of specific treatments that get at the mechanism that's driving the illness. In terms of novel treatments from a biological perspective, we have, and others, sort of started to systematically explore those. I'm sure you heard about ketamine, psilocybin, metroleptin, brexanolone. nutritional ketosis, which I will be talking about, and cannabidiol. So there are novel agents that have promise, and so we'll see where this all will go. And now we're gonna talk about nutritional ketosis. And before I get more into detail about that, I want to talk a little bit more how we conceptualize and how we think about the neurobiology and how we can fit these novel treatments in. One approach is, of course, we have a treatment and let's see if it works. Let's see if it does something. But the problem is if we don't have a model how it would work, then it probably makes it less likely that a novel treatment could be useful. So how can we think about anorexia nervosa? It's often very chronic, right? We talked about the deleterious effects, and I'm always thinking there must be some intrinsic motivation that helps to perpetuate the illness, so to speak. And I'm not saying necessarily something volitional, but biological mechanisms that drive this vicious cycle of food avoidance, losing weight, maybe binge eating, maybe purging. And this is a slide that you saw last time, and I still think is very important. So something that draws people in and that makes it very difficult to leave this cycle. And the overarching hypothesis and model that we have been working with is that there's usually a trigger, and the trigger is not just one event as far as I can tell, but there's certain motivators, let's say, and maybe a kid wants to get better at school soccer and get on the A team or so forth. There's like different motivators. Somebody wants maybe to lose weight. Somebody else has maybe a difficult traumatic experience and doesn't want to fill their body. And then they change their eating. And that can be food restriction, maybe followed by binge eating, purging. And really important is that once you change your eating, there are two important things. One is there's a change in expectation and learning. Food and eating become negatively conditioned stimuli. So you change how you think about food. And once that happens, you automatically develop a certain level of fear of weight gain or becoming fat or any other body-related aspect that makes you change your eating. So that's one part. That's kind of something where you took yourself towards. And then there are these unconscious biological adaptations, change in body homeostasis, the GI tract changes, and also change in neurotransmission. So change in dopamine, serotonin receptors and levels of neurotransmitter. And then we believe there is a vicious cycle that then have these different aspects interact and reinforce each other. And then we conducted a whole lot of studies to support this. And this is roughly how I explain to a family or a patient how we think the eating disorder developed. I like to think about this original motivation to get thinner. I want to get better at the sport and so forth. And then in the prefrontal cortex, you kind of condition with the fear to eating, and food and eating becomes a threat. And if there's anything threatening to us, then we get into a fight or flight or freezing response, and that activates a fear-driven circuitry that controls food intake. Because if you are in danger, you don't want to eat, you want to fight or run away from that danger. And then it changes how the hypothalamus drives your eating, kind of a mind over matter type of thing, and also driving dread and avoidance through the dopamine D1 and D2 receptors. And you may or may not remember that from last time. And furthermore, food restriction and weight loss sensitize dopamine circuits. So they get more responsive, and paradoxically, that then strengthens this food control circuitry, makes it even better, if you wish, to override the hunger drive, makes it even easier to control your eating, which of course is the real problem, and then leads to this vicious cycle of food restriction. So this is still the model from last time when we met, and this is how I essentially tell families how I think this works, and typically it resonates well with them, and they can relate to this course of illness development. What's also really important is what I want to highlight is when you work with people in therapy and you help them get back to a more normalized eating, you help them with mood and anxiety in context of all that, I find it always very, very important to go back to this original motivation, this original reason why people change their eating in the first place, because that often had not gone away at all. And that is still very deep sitting. And I think it's really important that we focus on that in this course of treatment. Now, with the treatment, we target observed behaviors and neurobiology. What we typically do is we target these conditioned fears of eating, weight gain, body image with psychotherapy, right? We use maybe CBT, CBTE, FBT, family-based therapy to manage those fears, with some exposure, with cognitive strategies. That's one aspect, and that can be very, very successful. And on the other hand, what we have been doing quite a bit, we use aripiprazole as a biological strategy with the idea of desensitizing this dopamine circuitry. And aripiprazole in the animal model has also been shown to enhance cognitive flexibility, to so make it more easy to be reasonable, make it more easier to figure out what's my best option. And I think that's what often gets lost in folks with eating disorders when they are preoccupied with fears of shape and weight. But they sit in the hospital for weeks and weeks, and I think there's a mismatch of cost and benefit, so to speak. And the aripiprazole we have obviously not FDA approved or any such thing, but aside from our small studies, there was recently a retrospective chart review of another group that showed that it was helpful in their treatment. And it's not something as a standalone intervention, but more to support psychotherapy, to make psychotherapy more effective, efficient. That's where I see this medication really come in. So that's our treatment model for the most part. Where sort of I work in our Rome, but to be honest, with the Abilify, I feel like, is it like giving insulin for diabetes, right? We have a problem and let's make this better. Let's fix this. The Abilify also is often very useful for helping with emotion regulation. By the way, I see a lot of folks who have like sort of oppositional defiant behaviors that were kind of buried and then somehow come out throughout the eating disorder. And I see this also be particularly useful there. But can we go maybe to a more underlying problem? Can we go further back, let's say, in terms of neurobiology? And that is then when I met Barbara Skolnick, who got in touch with me and told me about her niece who had anorexia nervosa for 15 or so years. And they ran out of options. The family had done everything one can in terms of treatment. And Barbara is a physician and she looked around what are other options, and then I want to say what was left in a way was the ketogenic diet as a novel mm, treatment for psychiatric problems as well as ketamine. And she convinced her niece to get on the ketogenic diet, and she really improved. And then they added on some ketamine, and she then recovered, and she has been well ever since. So quite amazing and striking. And then Barbara and some others, Lori Calabresi and Beth Subekania, they then did a small study on 5 individuals who also had chronic anorexia nervosa, but they were weight normalized and thought, well, maybe we can replicate that. And what they did was they had these 5 adults and they underwent this therapeutic ketogenic diet. And when you read about ketogenic diet, you typically hear about it in the context of weight loss. And of course, that's not our goal. And that's also one of the biggest concerns people have. They tell me, you're gonna kill people, you're gonna drive them into the eating disorder and the restrictive diet and all those type of things. So these are the concerns. And working with folks who are weight normalized, that reduced some the worry because they were in a good place overall weight wise, but they still were very preoccupied with shape and weight concerns. And so the diet, the ketogenic nutrition was aimed at weight maintenance essentially. And then they added ketamine infusions and followed them over 6 months. And all 5 did really well. And some of them stayed longer in the ketogenic nutrition before they started the ketamine infusions. And they just improved a great deal. And here are on this 5 individual case series, the data in red is where they were on the ketogenic nutrition only. And then later on, there was the ketamine added and then a follow-up period. And you see with the ketogenic nutrition, they went quite down a bit on the EDEQ, the clinical impairment assessment. You see a dramatic drop, whereas the eating disorders recovery questionnaire scores, they went up. So people felt like they start getting better. And they had, this was particularly cool, this green line acceptance of self and body quite nicely increased over time, whereas the body mass index was essentially flat. One person lost a bit, but stayed within in a normal range. Somebody gained a bit, so was very reassuring that it would not automatically cause any problems or weight loss of the eating disorder. So that was very cool. That's kind of when I got involved and could help with analyzing the data and all. And then I started thinking, okay, so this is just mind-blowing to me, these data. And I haven't seen that in, throughout my career, how fast things can change. And then I started thinking, so how could replacing sugar with fat for energy delivery to the brain improve anorexia nervosa, right? How could that be? It doesn't seem to be what we typically think. And we hear, as Kim already mentioned, there's the idea of all foods are good foods and stuff. So, yeah. So there was, over the past several years, there was some interesting genetic evidence coming out, so to speak, that showed that energy metabolism genes were somehow different in folks with anorexia nervosa. And there is a chemical creatine, which has to do with energy and metabolism. Then a lipid metabolism regulator gene was different. And here the glycemic traits, meaning biological traits that regulate sugar levels in the body, they were somehow different. And then Cindy Bulick call it anorexia nervosa, maybe a metabopsychiatric, may have a metabopsychiatric origin. So there's like this psychological, psychiatric part, but also a strong metabolic part that could contribute. So kind of hardcore, if you wish, research evidence that supports the involvement of metabolism. Now, what always has struck me is anxiety and stress. And in my clinic, regularly in the past, I'm trying to preempt that now and prevent that. But what always is so happening is in August, several of my patients relapsed. And I work mostly with kids, adolescents, and young adults. And what happens in August, school starts, right? It's a tremendous stress academically, socially. It is quite stressful. And I always felt like that the anxiety drives a wedge in their well functioning, and that brings in the eating disorder. And we all know about this feeling of being in control, having the eating disorder, having something to control and in a kind of a difficult to control environment. So somehow anxiety, I feel like from a general level, really is a huge problem that makes it more likely for the anorexia nervosa to come in or kind of return after people have re had recovered for some time. Now, looking into animal literature, I then found how much sugar is affecting glucose metabolism. So stress susceptibility affects glucose metabolism and brain function. Stress induced decreases in local local brain sugar utilization was found in another study. Another study who found that stress had an effect on energy metabolism in mice, and chronic social stress in mice alters energy status, including higher glucose need, but lower brain utilization of the sugar. And that's really bad, right? You have stress and you need more energy, more sugar, because our brain typically uses only glucose to get its energy from, but the stress makes it harder to use it. So that's totally paradoxical and made me think, wow, I mean, the people we work with, they're perfectionistic. They want to do the right thing. They're very hardworking, and there's always a certain level of stress. And then that uh, it, it could be sort of a self-made, not by choice, but sort of an inherent problem with elevated stress that might make it harder for you to use sugar well for all what you have to do. Same with anxiety, which is of course related to stress, but can be somewhat separated. Anxiety affects glucose regulation. There's an association between anxiety and metabolic syndrome, and stress and anxiety again affect glucose mobilization in relation to anxiety like behavior. So a lot of evidence how these associated behaviors that we see in folks with anorexia nervosa have an effect on metabolism. So what I think is the case in anorexia nervosa, and maybe a transdiagnostic problem, if you wish, in eating disorders, is there's elevated anxiety and stress. There's an elevated brain glucose need, but there is maybe a decreased brain glucose utilization, making it very, very difficult to then function well because you want to have the energy for all the good things you want to do. And so, what if then this anxiety, stress, perfectionism interferes with glucose metabolism in anorexia nervosa, and essentially the eating disorder, the weight loss becomes a way of self-medicating? Because what always has struck me is the ketosis state, when people are in the weight loss state And that comes at a certain point with ketosis, meaning you use up all your sugar and then you break down your body fats and then you use those for energy production. So your brain switches from using sugar to using ketone bodies, which is the breakdown product of fats. This state, I feel like, has almost something addictive for many. It's like they want to do more of the same, and it's positive, a positive experience at some level. So I felt like there must be something biological. And what if this state is actually the preferred state? And because it creates these ketone bodies for energy use. So um, that's what I started thinking. And so looking at from a metabolic perspective, and of course, using up all your energy resource in the body lead to death. That's of course the problem about this model. And again, as a means of self-medicating, treating this metabolic problem. And we're all wired, I think, to sustain our well-being in a way. And while, of course, starving yourself leads to death, the sense of not having enough energy is maybe superseding this other aspect of potential death that is not seen at the moment. So if you want to refine that a little bit more with data and doing a lot more reading, and that's what I mentioned here, this path of getting into this field and uh, being convinced that this has an important role in anorexia nervosa, doing more reading, I put together this model together with Barbara. And so again, we want to think about glucose is usually used for energy production in the brain, supporting brain function and behavior. But in folks with anorexia nervosa, stress and anxiety decrease glucose utilization. Susceptible individuals who also are maybe anxious have learned to be afraid of getting fat or have some body satisfaction. They then find starvation uh, as something positive. So they, all kids, right, or adults, we get into sometimes when we eat less. It's just a hiking trip or whatnot, right? People get into a certain level of starvation, building ketosis, getting into ketosis and building these ketone bodies, creating energy from those. And interestingly enough, the ketosis state is also associated with an increase of GABA, making more GABA out of glutamine and glutamate. And that leads to neuronal stabilization. Ketogenic diet and ketosis is a treatment for seizure disorders. So there's a strong history in research that the GABA system is affected, and so GABA calms people down. We know it helps with reducing anxiety. And then the folks with anorexia nervosa learn that this ketone-derived energy is more efficient because it seems to be less affected by anxiety and stress, leads to feeling less anxious and reduces starvation, right? If I feel like I have more energy from this and I feel less anxious, then I just feel better, right? And of course, it comes at the expense of death, which is the problem. However, if we apply a ketogenic nutrition, if we give a ketogenic nutrition that gets you into the ketosis state, that might solve the problem. And what is ketogenic nutrition? I'll show you in a moment, but essentially changing from your whatever diet you have been using to a diet that consists of 70% fat, 20% of protein, and 10% of carbohydrates. So using that distribution of macronutrients, you then change the metabolism in your body to switch from using glucose because you don't get anything through your diet. You switch then to using the ketone bodies for energy production. But of course, a ketogenic nutrition that gives you enough energy that you do not lose weight, and essentially mimics the starvation state. And if you have this better energy source, then, I was thinking, well, maybe then you don't have any drive to starve yourself, right? Because you're already well supplied with energy. So that's the idea, that you wouldn't need to restrict and so forth anymore. And then we were lucky that we got funding from the Bazuki Group to do a trial in anorexia nervosa and ketogenic therapy. And our goal was to test the effects of ketogenic therapy in folks with anorexia nervosa who were weight recovered but continued to suffer severely from drive for thinness and thus at high relapse rate. And we hypothesized that, similar to those 5 individuals that Barbara and her colleagues studied before, it would be well tolerated, would not lead to weight loss, and suggesting that the therapy would be safe. And then second, of course, assess symptoms, hopefully finding improvements that they have seen before. And that over a 12-week course. So why a 12-week course? Neurology, as I mentioned, has used ketogenic diet for about 100 years or something to treat seizure disorders. And their finding is that you should do that for 12 weeks to see whether it works or whether it doesn't. And so we borrowed from the literature, and we hypothesized that the ketogenic therapy would reduce the drive for weight loss, fear of weight gain, just make everything lighter, being less preoccupied with shape and weight, with the idea that the improved energy metabolism would just make it less important to then go into starvation. And we also collected saliva to study genetic underpinnings of the ketogenic diet effects in those folks with anorexia nervosa. Here's a general study design. It was an open label study. We cannot really blind this, and we thought we'd just do a one-arm open label study to see whether we can replicate the previous results. People had a screening visit, diagnostic interviews, and so forth. And then they had 2 weeks of therapeutic ketogenic diet induction, meaning over 2 weeks, a dietitian and myself helped them then cross over from the regular diet into a ketogenic diet, and then 12 weeks of full ketosis. They had weekly follow-ups with the dietitian and myself, and they submitted behavioral assessments and then exit assessments, and then we followed up at a 3-month visit. They were instructed to have 3 meals and 2 snacks per day. We were not super strict about that, or I mean, we couldn't oversee that on a daily basis, right? But that was really the goal, and people were given a scale for at home that they could weigh themselves on. It's a blinded scale, so they wouldn't know what their weight is, and they wouldn't stress about the weight, but we could then see where their weight went and whether they were eating enough or not. That was our kind of safeguard on that front. As I said, the macronutrients were targeted to 70% fat, 20% protein, 10% carbohydrates. It's interesting. Many people think ketogenic diet is a high protein diet. I have to do a lot of protein, and then they forget kind of the fat part. So it's really important to clarify that early on, because otherwise people get really scared when they all of a sudden know it's about fat. So the earlier one really clarifies that, the better. We delivered meals through a service or had people cook themselves, and they submitted photographs to the dietitian to review how much they ate. And then the ketosis target range was between zero point 0.5 and 3 millimole per liter of beta hydroxybutyrate, BHB. And we did monitor that daily the first 2 weeks and then later weekly if things were pretty stable. So if some people had like more unstable levels, we found it helpful to do it every other day or every third day, so to help people to stay on track. And then we said, okay, people losing below 17.5 of BMI or BHB levels between zero point 0.5 for 2 consecutive weeks would then lead to withdrawal. And so there were our safeguards. Here is sort of the consort enrollment chart. We assessed 184 people. We excluded 121, enrolled 63, then excluded more based on laboratory values or they were not interested anymore. And then we ended up with a group of 22 who started the intervention, and 18 completed the study and 4 were dropouts. We analyzed largely all 22 in an intent to treat analysis. So whenever they dropped out, we then carried their value forward with the, using that as a statistical model, which is a typical way to handle dropouts. And so let's go to results. So this is a large data table in the first column here with all 22, the full sample, the 18 completers and 4 non-completers. And I added the non-completers versus completers in, so to have a look right away in the people who did not well or dropped out. And what separated them was age. So the folks who did not complete, they were younger. They had also then less of an illness duration. And they also had different carnitine levels. The carnitine levels, I don't have a great explanation for yet. But carnitine is involved in bringing the fat into the mitochondria and helping with energy, fat and fatty acid metabolism. So there seems to be a biological marker here, but it's just 4 individuals. So I think it's also difficult to make too much out of it, but it was quite elevated. It's quite significant, actually. But the main point I want to say is age was younger. And what we noticed is the younger the people are, the harder it is. So we're currently doing a follow-up study that also includes brain imaging and so forth. And it seems the younger people are, the more they're entrenched, and it's harder for them to get out of it. When people are a little bit older, they're past maybe the college stage, and things have settled down a little bit and have more of I don't know, more of an overview of life and all that. It seems easier. It's quite striking. And so we're trying to adapt to that. But literally like 2 weeks ago, somebody said, look, I moved back into the dorms and everything is chaotic and I have nothing to hold on to other than the eating disorder, right? So it's sort of the psychological aspect of it is really strong. And what we also noticed that the biological part improves, but then the psychological part totally lags behind. And I think it's not surprising because what we have been doing, how we have been doing things, right? These are ingrained kind of mechanisms, sometimes habits, or just the way how we do things. And those that take 3 to 6 months to really change, and only if you really work on it. So it's an interesting discrepancy between biology, I want to say, and then the psychology and what the eating disorder is sort of, if you wish, do for people, how they kind of use it as a help. There were the differences in medications they used or comorbid disorders. And here's a comparison of the folks who completed the study in this greenish color and the folks who dropped out. Two dropped out after 3 weeks and two after 5 weeks. You see the ones in blue who dropped out early, they couldn't even reach ketosis well. They also had relatively high scores on the eating disorder, and they and also were thinner. So it seemed like they just had a much harder time. They were younger, they had lower BMI, and had very strong eating disorder symptoms. And one of them said to me, "Look, I had this problem since I'm 5 years old. Now I'm 19, and I'm just not ready for that. I wouldn't know how to live my life elsewhere." And so the study didn't have enough therapy support, if you wish, to handle all that, and was also not the goal for that. But I think these are really important aspects to take into account when doing these studies. The other two who dropped off after 5 weeks had actually really high ketone levels, relatively low scores, and one said, "Yeah, I'm good. I don't need this restriction from the diet anymore. I'm just fine. I just keep doing this." And then she didn't want to do it anymore. So, but she also had less overall eating disorder levels, and the fourth one um, just didn't want to bother with also the restrictions. So these were kind of the dropouts. But again, it's just ends of two. Um, and so what changed during the study for people in the study? First of all, I want to say BMI did really not change much. And most importantly, it did not lead to detrimental weight loss and recurrence of the eating disorder. So on the left upper hand corner, you see kind of essentially a flat line of BMI with standard error of the mean across the sample. And here you see the individualized uh, data points. And I separated here in pre and post the intervention and then 3 months follow-up. And between the intervention ending and the 3 months, people were free to do whatever they wanted in terms of either continue following ketogenic nutrition or just going back to where they were before. And so the lines in black are the folks who continued ketogenic nutrition, the ones in blue who did not. And you see there's like a bit of a mix. Some people gained a bit, some people lost a bit. This person up here already had a quite high BMI and then more, and she had also quite a binge eating pattern that she had developed. During the study, she didn't really binge eat much at all. But then I think later, when she went back to the regular nutrition, it was not helpful. But overall, a quite stable BMI pattern. And the EDE Global, uh, which is a composite score of restraint of eating, eating concerns, shape concerns, and weight concerns, you see over time the left a quite beautiful decrease of scores. And an EDE global score of 4 is quite elevated. So this is a severely ill group. And then they went as a group below 2. And the cutoff for anorexia nervosa is 2.09 based on uh, past studies. So essentially, the mean was normalized. And here you see on the right, you see the individual participant data points. Again, the black ones who continued ketogenic diet later on, the blue ones who did not. Um, there's like 5 who were above 2, so they did not do well. But the remaining folks did really well, and they were actually all well below 2. So and you see there were even the the lowest one on pre was like a 2.8 or something like that. So it's quite amazing how those scores went down. And then you also see that many of those after the intervention went back up. Um, so that's the change over time. And here are the subscores for restraint, eating concerns, uh, over the 14 weeks, and then the individual subject lines pre, post, and at 3 months. And the same here for shape concerns and weight concerns. Very, very similar. There was like these 5 people who were just elevated. And we get to that in a moment, what distinguished those folks. But I have to say, one of them who was elevated went down on further follow-up. What also struck me is this. 3 of those who were elevated, they stayed on keto. So I feel like they were still hopeful, or they felt like they got something out of it, but it wasn't as striking yet. And one thing I think they did get out of it was depression being better. Meaning, here's the back depression score going down over time very nicely. And you see, as much as we had still 5 quite elevated folks on depression, I mean, they're still elevated here, but essentially everybody got somewhat better. And then even this person who was not so good, they continue to slowly getting better over time. So I think the effects on depression are quite important in this context. So now completers versus uh, successful completers versus non-successful completers. People with an EDQ global score below 2.09. So this is what I just showed you. And there's like these 5 people who are just high. And then we looked at what distinguished those folks, what makes them different. And here's like a huge table with a lot of assessments that we did. And we were just exploring what is different. And what we found different is novelty seeking, harm avoidance on exit was higher harm avoidance and lower novelty seeking, and depression was higher, and trait anxiety was elevated, and self-esteem was worse compared to the successful completers. Actually, they had the lowest p-value, if you wish. So quite striking. And then we were thinking, okay, so is it all of them, or is it 1 or 2 of those factors? Let's see that changes things. And then we did a multi regression analysis where we used those differentiating factors and looked at which one is really driving the EDE global on exit, what drives it. And you see this almost perfect line for low self-esteem. So higher low self-esteem on exit, so worse self-esteem was clearly associated with higher EDE global score. And you see that depression was almost flat. Trait anxiety showed actually an inverse relationship, quite striking. And novelty seeking and harm avoidance, again, they had no significant effects, is my point. So highlighting how much low self-esteem is driving the problem. And these very deep-sitting, long-standing feelings of worthlessness, and two had some traumatic experience, but the issue was, according to the typical PTSD assessment, it was not a life-threatening, or it was not a kind of assault, physical or sexual assault type of situation, but it was sort of something traumatic in the context of moving, schools, feeling alone. So it's a very interesting sort of in between, I don't know, factors, environmental factors that are not always well captured. But anyway, so low self-esteem has a huge impact, and I think we have to focus on that very much in our treatments. Here are data on side effects. You were maybe wondering, were there problems from the ketogenic nutrition? Side effects occurred in the beginning, about 40% of people, and then went down, some ups and downs, some nausea, not really vomiting, constipation, diarrhea occurred, but nothing that was truly concerning. And we typically recommend people have a lot of fluids, electrolytes added usually. Uh, Sometimes magnesium for constipation, occasionally Miralax, that type of thing. So, but overall, it was quite well tolerated. And um, sometimes people said, actually, in my other diet, I have sometimes similar symptoms. So, wasn't always clearly distinguishable. So, in summary, uh, the study was well tolerated, did not lead to weight loss or relapse. The trial was completed by 82%, and of those, 72% had behavioral scores on the EDQ global and depression within normal range. Symptom improvement in both eating disorder and depression scores in those individuals was remarkable, and self-esteem was a critical factor in those who did not improve well on the EDEQ. So it seems to me that therapeutic ketogenic diet could be an effective treatment for AN after weight normalization. And so we're exploring how that will go in underweight people. Having said that, we actually we always went with 17.5 as our underweight or within normal weight range criterion, but while the DSM doesn't really state it, over the past years with the WHO coming out with normal weight and whatnot criteria in terms of BMI, I understand now the general thinking is that anything above 18.5 would be underweight. So having that in mind, we did have a couple of people who were mildly underweight in the study, and so that went overall well. So here's something I would like to share. What a mother said of a patient who participated, and she said, "Your program has helped her more than anything so far, more than any medication or therapy, and certainly more than inpatient treatment. She's wanting to transfer back to a four-year college from the community college and feels she is ready." And she said she hasn't thought about her eating disorder for 2 weeks. So that was really striking. That was just incredible. That was also a person who had been quite depressed and uh, struggled with that for many years. And hearing that from a mom is just quite incredible, and making a life changing difference in that person's life. So, and these I mean, some people have it harder and some people it easier, and for some people it's more of a struggle, but some people really have a dramatic, oh my gosh, why didn't I know that earlier? Oh my gosh, why well, why haven't I done that? That type of thing. But it also takes a lot of coaching so people do it the right way. So recently I had somebody who the family just decided they would want to do that, and then she didn't get enough food and her ketone levels went to, I think, 7 or something, and she ended up in the hospital for rehydration. Um, so you have to do this in a controlled environment, and you have to do it right and provide enough food. So I want to then I think we have still a little bit of time, right? You said 10:15. Perfect. So I want to show you my expanded model for anorexia nervosa. And I started out with talking about last time we met and how I think anorexia nervosa develops. And so I have now an expanded model that's complementary. And so how I look at this as a person at risk for anorexia nervosa, that these predisposing traits for elevated anxiety, perfectionism, and motivated high achievers who often worry, right? That creates a lot of stress. And that during a critical time in life, meaning puberty, um, when there's an increased energy demand, you need more glucose metabolism. But then you have also psychological instability. I think that's an important part of the psychology aspect that I just talked about, this college student. And then you have, of course, peers and media influences and all that. And then you have, of course, the instability of sex hormones, neurotransmitters. This is kind of changing dramatically. So I believe that the anxiety then interferes with this increased energy need, and people don't feel well or feel stressed and feel they don't have enough energy. But then the psychological aspects, they kind of trigger negative conditioning and negative attitudes towards food, and then they change their eating. They restrict food and they lose weight. And this weight loss changes your metabolism, right? You lose weight and then you create these ketone bodies. And the ketone bodies, they then all of a sudden fulfill this unmet energy need. And that would, of course, reinforce the starvation state, because if there's something that makes you feel better, why not do it, right? It's a bit of an addiction model, and I started more and more using this term with people with anorexia, which seems paradoxical because they typically don't have as many drugs or alcohol as others. But I think that's their reinforcing biological compound, reinforcing the food restriction. And further, the starvation then increases GABA production from the glutamate and decreases anxiety. And who wouldn't want to have less anxiety, right? So this is fantastic. So there's a second reason why I want to do more of the same. People sometimes talk about this quiet place where they are, right? And so forth. And on the other hand, the negative conditioning then kind of changes your food control circuitry and changes, you try to restrict, but then this restriction sensitizes the dopamine receptors. So now we're at a whole different level of the brain, a different circuitry that gets affected. This more sensitized dopamine circuitry makes the food control circuitry paradoxically stronger. It's actually not paradoxically, because if you're out in the wild and you're starved, your dopamine wants to be sensitized because you want to find the berry somewhere on the bush or something like that, some food. But of course, here it has gone awry with the wrong association. Food has become a negatively conditioned item. And then the food control circuitry that gets stronger and then facilitates the food restriction. And then now we have a third self-reinforcing mechanism to bring about and perpetuate the vicious cycle of anorexia nervosa. And I think because anorexia nervosa is so against what nature tells us in terms of maintenance and body homeostasis, I think I've been thinking there must be more than one mechanism that drives that, right? So it must be some complementary aspects that override the typical mechanisms. Let's see. And then the therapeutic ketogenic diet then would provide the ketones and would provide the elevated GABA as a subsequent step, while keeping weight maintenance with enough of the ketogenic food, and help people stay stable and not be drawn to restriction. So you might wonder, and what about bulimia nervosa? What's happening there? Because you may remember I talked about the transdiagnostic model that I believe. And I do think it's the same problem. There's an inefficient glucose metabolism as a transdiagnostic marker across eating disorders, including bulimia nervosa. And so this is brand new. This is a brand new model. Same problem here. Anxiety and stress decrease glucose utilization, but it's not starvation that then helps the problem. It's more the binge eating helps you with it. because you get a tremendous amount of energy and then you kind of fill your energy resources and that makes you feel better for a little bit. But of course, it's awful because you're already conditioned negatively to weight and shape and all that. And then you want to throw up. So this is all hypothetical so far, but I think that the folks with anorexia nervosa, they may have a genetic predisposition that they more easily lose weight, and then they are drawn into the food restriction ketosis state, whereas folks with bulimia nervosa, they may be, they also try to restrict, but it usually or often doesn't work, so to speak, long term. And then they probably have a genetic predisposition to want more of the food, to gain weight more easily. They then solve the energy problem with more food, but then they want to get rid of it, have to get rid of it because of anxiety and throw up. So that's our model for bulimia. And with that, I'd like to thank a lot of people, and especially the Bazuki Foundation, who has been so helpful and supportive with this new treatment approach and looking for alternative models beyond what we have been doing so far. And with that, I'd like to thank you for your attention and be more than happy to respond to questions.
Wonderful. Thank you so much for that amazing presentation. And we do have some questions already in the Q&A box, but feel free to put some more in there. I have some as well, but let's just get started. The first question is, how many patients were withdrawn for losing weight below 17.5? I'm assuming 17.5 BMI is the question.
Uh, you mean who signed up for this study or who were withdrawn during the study?
I believe it's withdrawn during the study for losing
None.
weight.
None. I showed you all the data.
Yep.
So the four people who dropped out, they just didn't want to do it anymore. There was like these two people who couldn't reach ketosis and they were like, this is just too much for me. And two people who said, "Oh, actually, this is easy and I love it, but I don't want to have the restrictions of talking with you every week and that type of thing." So, but there was nobody who lost weight during this intervention. So,
Right. There was one subject that looked like who had lost weight after the intervention at the
at the
3 month
3 months
mark.
mark, yeah. So there is, but not to a dangerously low level is my recollection. But let's see. Yeah, no, there was nobody below 18 at the 3 months mark. I'm just looking back to it. So there was like somebody who started at 17.6 or something like that, but everybody was 18 or above. So there was this one person maybe that you looked at, it was like maybe at 19 point something, went down to 18 at this post, but then went up to 18 and a half, I want to say, or something like that, at the 3 months mark, a person who was on keto. So,
Yeah. But I think this question touches on probably a lot of what you get from eating disorder professionals. Why are we talking about something that I think many people in the eating disorder world associate with diet culture and
mhm,
weight loss as an intervention for somebody with
mhm,
anorexia. And I
yeah.
think part of that too is, I believe we need to be a lot more precise in the eating disorder field about what we mean by restraint or restriction.
Mhm. Yeah, I totally agree. I mean, we say food is medicine, right? Food is your
Hmm.
medicine. Now, do you take every medicine? Is every medicine good for you? Maybe not. So
Correct.
that's
Correct.
that's I just thought about that recently as I think a reasonable argument because not why does every type of food have to have the same effect for each person,
Right.
right? I mean, I just find that unlikely because we also are having our differences. Interestingly enough, I like I do not necessarily think that everybody has to be at the high level of ketosis. Not everybody has to be. There's by no means the higher the ketosis level, the better somebody is doing behaviorally. I do not think this is the case. There may be more of an inverse U-shaped curve, and the people between zero point 0.5 and 1.5 is my experience. They may be doing the best, and I don't also know how much in the end it will be about being in pure ketosis or sort of a back and forth maybe between or around the threshold. I'm not sure. I'm just sort of hypothesizing here, but I do think that it's reasonable to think that specific foods are better for some people and other foods are better for others.
Yeah, for sure. Here's another question. Can we expect similar results to a ketogenic diet in patients with atypical AN?
I would think so. I would think so. And that's a really good point. I mean, most of the people that we had in the study, they essentially technically had atypical AN because they were weight normalized. I mean, you can categorize them as partially recovered, or they were all underweight. But I would very much think so.
Yeah.
I would believe so.
And of the 18 completers,
Mhm.
how many had histories of ANR versus ANBP?
Oh gosh, I do not remember.
Was there a mix?
It was a mix, but gosh, it was like 70% or so A&R, and the others had binge purge uh, behaviors as part of the syndrome. So
Okay.
yeah, we did not separate by that. We also didn't really. I mean, the problem is with that number, then if you analyze it, you don't get really a power to have a statistically significant effect or effect size. I don't know. It's probably that's why we didn't really focus on that. Um,
Right.
but we did notice that uh, the people who were at higher weight and kind of developed binge eating later, then it wasn't easy. It was almost I feel like it's easier for the people with restricting type anorexia purely back then and now. And but I don't have really strong data to back that up. But that's my sense so far.
That's interesting.
Mhm.
Did any of the participants have comorbid substance use disorders? You
Not at the
dared to
time.
use the
Not
bad
that.
word addiction
Yeah.
in your
Not
talk
not
here.
not at the time of the study.
Okay.
Not at the time of the study. So we did not allow that as a
It was an
yeah.
exclusion
No.
criteria. Okay.
But what was interesting was there was one woman who um, had, so once, twice a week, quite a bit of alcohol. It didn't qualify for abuse. There was no interference. There was no really effect. But she said, you know what? I'm drinking less. And I felt like she didn't need it anymore to settle down, kind of help feeling less stressed. She felt more calm and she said, I go out and have a drink, maybe two. That's good. So it was without us doing anything. So it was very, very interesting. And there's
I
some
hear.
idea that ketogenic nutrition might be useful for people with substance use problems, alcohol problems.
Right. Another question, were there particular types of fat stressed during the study that made up the 70% fat example, saturated fats, unsaturated fats, or was it just any type of fats to create those totals?
Nothing specific. It is possible, but much harder if you're vegetarian. It is possible, but much harder. It is much easier to get the animal fats in. Um, and but no, long story short, no, we didn't stress anything. We just wanted people to have fats, and we often recommended to add some MCT oil to get extra fat if people had a hard time reaching ketosis or adding the fats. But some people they took a bottle of olive oil to work or something and poured it over their salad or chicken or whatnot, or so different ways. Many people liked having a lot of almonds as a snack or as an add-on. But no, we did not do that.
Okay. Another comment, fascinating. Can glutamine be supplemented, or does the increase in glutamine and therefore GABA need to come about as the result of ketosis? And kind of related to this, I was thinking, have you used GABAergic medications
Mhm.
for these folks, or do you think that would be helpful?
Yeah, I don't think there's convincing evidence that that type of supplement would enhance GABA in the brain. I don't think, I mean, you would think, but then it has to go through the guts and maybe the liver and whatnot. And I don't think it ends up on blood-brain barrier. I don't remember if how well that crosses the blood-brain barrier, but I, from my reading in the past, I don't think I would support that. That the maybe question in the same direction is how well do maybe ketone supplements, how much would they do the trick? Because you can give ketone supplements and you can increase the ketosis level or the BHB level. And we're just analyzing data right now on that. So I think that could also be an interesting aspect. But then it's also some discussion what type of ketone supplement do you use and things like that. So the glutamine, I do not think I see a benefit in that. But again, the keto supplement could be something to consider.
Okay. There's a couple of questions actually about, you know, any evidence or any thoughts about long-term use of a
Hmm.
ketogenic diet? Is it safe?
Hmm.
And related to that, what does the off-ramp of
Hmm.
the 12-week intervention look like for for patients?
Yeah. So we just left it up to the people whether they wanted to stay on it or not, and we provided them with resources as a help if they wanted to stay on it or whatnot. We didn't have a particular off-ramp procedure, and we just want to see a natural follow-up. And I mean, it's quite striking. For many years, fats were kind of the bad food group. And now things are kind of changing. I remember, I mean, it was maybe 10 years ago. I went to the Society for Neuroscience meeting in DC or so it was, and there was a poster about an animal model and anorexia nervosa, and what helped normalize their dopamine neurons were fats. So that was actually the first time that I really started thinking about fats and the brain and anorexia nervosa. And when you think about it, these insulations of the nerves in our brain and elsewhere, they have a lot of cholesterol in them. So it cannot be all that bad. Of course, I'm aware of heart problems and whatnot, but there's maybe more conflicting evidence out there than we might think. The other problem is it's probably really bad if you have a lot of cholesterol plus a lot of sugar, and then you get the insulin resistance and so forth. There's also probably an aspect of you have to train your mitochondria to utilize these different energy sources. So it's not just you eat something and things happen. It's just like with everything else in the body, you kind of have to activate a certain mechanism. So long-term effects from my reading is that we may have to be less worried about cholesterol and cardiac effects than we may have thought, but there is ongoing research going for that in the short term. I think if you suffer from a problem that makes your life very, very miserable,
Or
I
might kill you.
or kill you, so I would not worry about that as much. We did have a person who came back to us and said, "Yeah, my LDL has been higher now than before, but interesting enough, her HDL was through the roof." So uh, yes, it's higher, but it seems like the ratio between those wasn't bad per se. So um, yeah, that's about what I can say. But the other important question is how much keto do you have, like, or what has to be your ketone level on a long-term basis to feel well? And second, it doesn't have to be cholesterol and animal fat. So avocados and nuts and things like that. Um, yeah, they're quite good. Um,
Yeah.
so.
Okay. Here's one. If someone has a fear of carbohydrates, which is a lot of ED patients, how do we tell them to heal their relationship with carbohydrates and creating balance while also telling them to eliminate or reduce carbs to a very low level? Does that not exacerbate the fear of carbs?
So I have not encountered that in the study. So that has not been an issue. But what I mean, I don't know what that person who just asked a question experiences, but most people that I work with, they feel more afraid of fat than they feel afraid of carbs because fat has much more energy content and uh, is much more uh, has a danger of weight gain than the carbs do. And I almost feel like, and to be honest, getting on this nutrition, boy, that's pretty hard for most of them. That's not, it's not easy. And it's not like, oh, I can skip the carbs. Oh, that's great. And I have the fat now, and that's easier. So that's really not the case. It's really hard. And I almost feel like it's the opposite. I I mastered my fear of fat, and maybe I worry less about the carbs now because the fats are the thing that makes me, at least in my thinking, fat the most. And if I handle that, I don't even have to be as afraid of the carbs. It's actually a total different uh, perspective. So that's why this concern about this restrictive eating and being having a better relationship to food and whatnot. I don't think uh, the better relationship with food comes necessarily by eating everything the same. I think the better relationship with food comes from if you have a better relationship with yourself and if you have a better relationship with your body. And if
And your
you
biology,
right.
correct.
I mean, the thing is, we don't know. I mean, I don't know what's happening in my brain right now, right? But I know how
Yeah,
I feel. And if I feel
right.
pretty confident, if I feel pretty good, then I will have a much easier time to handle stress from work or from maybe those eating disorder thoughts. And then I can think, okay, maybe I don't have to worry these things as much.
Yeah.
So I think uh, like let's say you have a phobia and you put somebody in an airplane to reduce the anxiety of flight fear of flying, that's one thing, but I'm not sure if it works exactly the same in eating disorders. And you could even say people with anxiety disorders, maybe they also um, have some metabolism issue. I don't know. We don't know that, but the animal literature would suggest it because anxiety is associated with these metabolic issues. So, I mean, I hear these comments all the time, and I I entirely take them very seriously, and I've been thinking many hours about that. And because the last thing I want to do is harm. Uh, It's just like I think maybe we have to look things from a different angle. And maybe this fear that they then have a bad relationship with carbs, I just haven't seen it. I just, this doesn't come up. And again, I think having a better relationship with fat, then maybe making the relationship with carb was actually better again, because the worst that could happen, me gaining weight and getting fat, is more likely from the fat than the carbos.
Yeah. Well, I think too, if we look at your data, EDEQ or EDEQ restraint subscales go down. So you can
Right.
be, this is part of what I meant when I said I think we need to be a lot more specific when we talk about restriction or restraint as eating disorder professionals, because you can have a meal plan that is restricted in some macros or in some specific substances in it, but still have that meal plan be calorically replete,
Right.
even hypercaloric,
Correct.
and potentially have it be a source of energy that their brain can actually use.
Right.
Um, and we don't know what's going on in our brain, but we make up stories about how we feel,
Hmm.
and that's the psychology.
Hmm.
Um, so I think your data, shows what you described, that these patients don't have worsened relationships with carbohydrates
Hmm.
after the study, which I think is paradoxical for
Hmm.
most of us if we're thinking primarily about eating disorders as psychological syndromes. Um, okay, is there going to be a follow-up study to see if patients sustained recovery long term? When they go
So
back to eating normal again, did the ED increase again with eating more carbs again?
So the data that I showed you, the 3 months follow-up, they're a bit mixed here. For some people, you see a dramatic increase right away from post-intervention to 3 months follow-up. We do a study now with a bit of a longer follow-up, a study that also includes brain imaging of glucose metabolism in the brain and see whether we can tie it to such a marker. And there we follow people for 6 months. So uh, extending the what I showed you just here, and then we'll see how that goes. My sense is there are some people who do not follow strict keto anymore, but then when you get into detail, they still have a more higher fat-based intake. And so it's quite interesting. It's just I think we do what we from some internal sensor seems to be right, and they then feel it's better for them. So I think people still stay in a lower carbo state, but not because they're afraid of carbos, but more like, well, I just feel better on the other. So more, and many people talk about freedom. They feel now more free, less preoccupied, and I think they are more free to choose because the eating disorder does not give them freedom at all. And
Yeah.
so, yeah, so we are following people in a follow-up study longer now, and we'll see what that will bring.
So we'll have you come back next year.
I'd love to. More than happy
Wonderful.
to be here.
One last question, and then we'll be at time. What about hypoglycemic reactions? How prevalent were these, if at all?
Yeah, we didn't have a problem with that at all. one thing I thought I want to mention is we had recently someone in our imaging study when they come back for a second scan, and um, that person was so they have to fast for 8 hours before the scan because there's a competition between the glucose that's get injected and then one that's in the blood, and then they're supposed to fast. And then aside from the fact she didn't eat many carbs because she just felt so good on the keto nutrition, and she had a blood glucose of 54, and that would be typically concerning, right?
Yeah.
But she was perfectly fine. She had absolutely no symptoms. And
Oh, wow.
I think she is a super user. And she had high ketone levels. It was not a ketoacidosis or something like that. But she had relatively high ketone levels compared, and she was always like, I think 2.5 or something like that. So more the upper end. But I think I said, I wonder if you're a super user, like a ketone super user, because she was energetic and she was happy and all that. So it's like amazing, amazing. So I
Yeah.
just think she gets all her or most of her nutrition or energy from the sugar, and not from sugar, from
The
the
ketones.
ketone bodies, and the
Yeah,
sugar
yeah.
is just not, it's just replaced. So there was no, yeah. So we did not have any problems with that on a clinical level or on a that people had any symptoms or any such thing. And that was also only because because of the scan, she fasted, and I think that was sort of a combination of those things, and we discussed about it and follow up and whatnot. But she also said she historically she always has had a lower blood sugar, so I think she maybe just yeah, just using the fat derived energy really well.
Wonderful. Well, that is all the time we have for today. Thank you again, everybody who came. You will receive an email with instructions to obtain your CE or CME. And thank you again, Dr. Frank. This has been fascinating and wonderful. Really appreciate your time and your expertise today on a disorder that is still killing a lot of people um, every day. So thank you.
Thank you so much again.
You.
Bye.
All right. Take care, everyone.